You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Month in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
March is Colorectal Cancer Awareness Month, and to speak on this topic, we have Zach Getty joining us. Zach has worked in a variety of clinical and hospital settings and is currently the Patient Education Program Manager at Fight Colorectal Cancer. Welcome.
Hey, thanks for having me.
Thank you so much. Wanted to have you just tell us a little bit about your healthcare background.
Sure, yeah. So I'm currently the Program Manager at Fight CRC, but I actually started working in healthcare, first job right out of the gate at 16, and worked in kind of a variety of settings really throughout my entire adult life until I got this job. So I've worked in patient care settings pretty much the entire time. I've worked on med-surg floors. I spent a lot of time in emergency departments and orthopedic clinics. And then really most recently, I worked in a field called neurodiagnostics where we ran EEGs, and I spent a lot of time in the OR working with neurosurgeons, making sure that they weren't, for lack of a better word, paralyzing people during spinal surgery, brain surgery, that type of thing. So I've kind of had a varied background, kind of worked in a lot of different disciplines in my time in the hospital. So,
yeah, you sound very well-rounded. What are some colorectal risk factors?
So there's a lot of risk factors for colorectal cancer, and a lot of them you'll see are kind of similar to other cancer risk factors. But, really the main ones are age. The older you get, the more likely you are to be diagnosed with colorectal cancer. If you have a personal history of polyps or cancer, that also kind of predisposes you to colorectal cancer, of course. Inflammatory bowel disease, IBD, or Crohn's disease is something that people might be familiar with. Those are all risk factors for CRC as well. Some of the ones that kind of apply to a lot of cancers and are no different for colorectal cancer are family history or genetics, smoking, excessive alcohol use, fatty diet, just poor diet in general, obesity, which kind of goes hand in hand with poor dietary habits sometimes. And then there's some demographic risk factors as well for colorectal cancer. African American communities in the United States specifically have higher risk factor for CRC. People of Eastern European Jewish descent, Ashkenazi Jews, have some of the highest rates of colorectal cancer in the world. And then indigenous communities in the United States as well. So American Indian, Alaskan Natives, those are all situations that predispose you to being diagnosed with CRC. And then just generally, again, like a lot of cancer types, just if you have a lack of access to healthcare, you're also predisposed to being diagnosed with colorectal cancer.
What are common symptoms related to colorectal cancer?
So there's a lot of them, but I always like to start this conversation with sometimes there's no symptoms at all. It's not uncommon for people to go in for a colonoscopy and be diagnosed with cancer when they were having no real symptoms that would point to that being an issue. But some of the common ones that you hear people reporting are, you have an ongoing change in bowel habits, which can really mean anything that just, if it's different for you, that's a change in bowel habits. Not everybody has the same bathroom habits. But the important thing is in relation to how you normally go to the bathroom. If you have an ongoing change that lasts for a while, that can be a symptom. Stools that are more narrow than usual. And this one always gets questions. So, like thin, like ribbon shaped or pencil shaped stools can be kind of an indicator that you may have a tumor in your colon and your stools are thin when they have to pass through that space in your colon. Blood in your stool or rectal bleeding, frequent gas pains, bloatings, feelings of fullness or cramping, kind of feeling like you also can't fully empty your bowels can be a indicator that something may be going on. Like most cancers, weight loss for no reason, or if you're not really trying to lose weight, can be a problem. fatigue, tiredness, weakness, really all of that. But yeah, the no symptoms at all is really a big one that I really like to hit home with.
Can you share with us maybe the prevalent rates of colorectal cancer?
Yeah, and this is actually somewhat frightening. So right now, and these stats are frequently updated, so this may change in the near future, or it may be different right now, but approximately like 1 in 23 men and 1 in 26 women will be diagnosed with colorectal cancer in their lifetime. So in 2023, this year, the ACS, American Cancer Society, estimated that there'd be over 106,000 new cases of colon cancer and 46,000 cases of rectal cancer in the US. So they are different. Colon cancer, rectal cancer are different, but we kind of lump them all together as colorectal cancer because it's similar disease states, and your colon and rectum are obviously attached anatomically.
Mm-hmm.
And the current projection for 2023 is that 52,000 people will die from the disease this year. In 2019, there were an estimated 1.3 million people living with the disease only in the United States. And colorectal cancer is the third most common cause of cancer death in both men and women in the United States. And if you combine men and women, it's actually the second most. And then really projections for early age onset colorectal cancer are pretty frightening as well. In 2030, so, it really seems like it's in the distance. We're almost in 2024 right now, but it's estimated that colorectal cancer will be the leading cause of cancer death for those ages 20 to 49, which 49 is the cutoff for early age onset colorectal cancer.
What are the stigmas of screening for colorectal cancer?
So these are kind of all over the place, and really a big one, and this is kind of hard to address tactfully, but you're just coming out and say it. A lot of men, particularly when screening for CRC, you have a colonoscopy. It's pretty much considered the gold standard of screening methods, where a scope camera is inserted through the rectum so they can actually look into the colon. Physician can actually visualize the inside of the colon. And for a lot of men, you're not going to touch me back there. It's gay. You can't get close to my rectum. It's not okay. And so they're unwilling to even be screened for it. It's also kind of typically considered an old white guy's disease, for lack of a better term, and it's really just not the case. So a lot of people just don't get screened because they don't think they fall into the general population that would typically have colorectal cancer. Colorectal cancer isn't also, again, for lack of a better word, a sexy cancer. It doesn't get a lot of attention like, breast cancer. They've got Susan G. Komen and really a large visual or a large presence in the media and stuff like that. And it's not something fun to talk about. Cancer of the colon, rectum, it's not pretty. And so people just kind of turn a blind eye to it. There's also stigma that surrounds some of the treatments for colorectal cancer. There's lots of stigma around, having an ostomy, body image issues. And again, colorectal cancer is one of those diseases that you'll hear people a lot of times saying it's preventable, or at least somewhat preventable. And so unfortunately, there's a stigma with diagnoses with colorectal cancer that, if I was diagnosed with this, did I not do enough to prevent it? Did I do something wrong? Is this cancer my fault? And these are all things we try to address, try to get away from, but, the stigmas persist, unfortunately.
Yeah, you did mention some of those lifestyle changes that are perhaps a colorectal cancer risk factor.
Sure.
And you named several of these preconceived or assumptions on the diagnosis itself.
Absolutely.
One thing that you had mentioned was that there's also these perhaps stigmas related to treatments. And I was curious if you could speak to treatments, perhaps.
Yeah, so treatment for colorectal cancer is really dependent on diagnosis and the stage of the cancer that you're found with. So obviously, catching any cancer early is ideal. And that's really why, colonoscopy is kind of considered the gold standard of colorectal cancer screening methods, because a physician can get in there and look, and if they find anything that's problematic, like a polyp or a precancerous polyp specifically, they can remove it right there, send it off for biopsy, and you're done. Stage 1 cancer, typically almost all of colorectal cancer is treated surgically. You do what's called a resection and take out the section of colon that is diseased. And depending on what stage you are, it can either be as simple as that, take out that section of colon, so you back up and, watch and just monitor you for a while afterwards, all the way to, if you have stage 4 colorectal cancer, metastatic disease, you've got distant metastases. Typically, we see that most commonly in the liver with colorectal cancer, and then treatment just gets more complicated. So some common treatments, some people require an ostomy afterwards, which can be either permanent or not. It's really, it just depends on your unique situation and how you present with the disease specifically, and what other health problems you go into the diagnosis with. Unfortunately, it's really hard with anything health related to give a one size fits all answer, but there's a variety of treatments, and really early detection is key, and making sure that you catch it as soon as possible and then monitor afterwards. So.
Thanks, Zach. I do appreciate that acknowledgement that there are going to be those individual differences in treatment. And there isn't really just one size fits all, and talking about what that would look like to then have the cancer treated appropriately. I wanted to ask about perhaps some common healthcare disparities seen with colorectal cancer patients. You started to speak to a little bit about some of those perhaps ethnic groups that are at a greater risk, but wanted to just talk about maybe some of those disparities.
Sure. So, I mentioned earlier that a risk factor is lack of access to care, which is, it's common in rural areas. We're fairly fortunate. A lot of the people I work with who've been diagnosed have access to some of the best care in the United States. They have academic centers. They're all over the country. But if traveling for 3 to 4 hours to go get treatment is your best option, and you simply do not have the ability to do that, it creates problems. And you may be getting treatment in an area without specialized care for colorectal cancer, or without access to groundbreaking treatments or newly approved drugs, that kind of thing. So, really the lack of access to care corresponds with income disparity. People with fewer financial resources are less likely to be able to afford preventative health care, which increases your risk of acquiring CRC or being diagnosed at a later stage if you're not able to access the screening methods that would have, caught it earlier. There's also, we see a big problem, and this is a common story among the people involved in our organization, our ambassadors, people that we have connections with, is something we call medical gaslighting, which I'm not sure that the term gaslighting is becoming more popular just in common dialogue, but medical gaslighting specifically, oh, you're too young to have colorectal cancer. That's not what's going on. Oh, you just have constipation. You just have hemorrhoids. You just have XYZ, this, that, or the other. And just not being seriously.
The dismissive attitude, sorry.
Absolutely. It's super common. We see stories all the time where people go, I was talking to my primary care physician about this ongoing problem. I was anemic. I was having all these issues, bleeding, whatever, and they just would not take me seriously. And I wound up in the ER, and they ran a CT scan, and, oh, you have cancer. And it's, it's been ongoing. And it's seen really commonly. We hear a lot of stories from people about this in Black, brown communities, and then people in the LGBTQ communities, and especially in the EAO space, which is early age onset, as I briefly mentioned earlier. It's just getting someone to listen to you and take your complaints and your issues seriously it seems to be like an uphill battle more often than it should be. And it's frustrating.
Yeah, I could actually relate to that. My diagnosis as a young cancer survivor, and very similar experience where I guess now I know it was medical gaslighting. They're like, you have really bad headaches and you go blind. You just need some ibuprofen.
Yeah. Drink water.
Yeah. You'll feel better. I'm like, but I feel like something is really wrong. They're like, no. You're just too young for any issue. So yeah, I can really relate to what you're saying on that topic. What current research is Fight Colorectal Cancer participating in?
So Fight CRC, we're not a direct, we don't do research directly ourselves, but we put on, we actually just a couple of weeks ago, we had an early age onset, a think tank in Nashville where we got, gathered a lot of people in the early age onset space, physicians, researchers, stuff like that, to kind of gather and really discuss what are we seeing as an organization? What are we looking at? What is causing this pretty frightening rise in early age onset cases? We also published a year or two ago, we call it our Path to a Cure, which is more than anything, it's an outline for how we are going to go about hopefully curing this disease. It's, not to brag on Fight CRC too much, but it's really kind of a groundbreaking thing. It's a multidisciplinary publication. It's really designed to kind of summarize and communicate a plan for our community, the CRC community, to rally around. It's designed to really kind of push forward critical areas of research, care for patients, policy, early detection and prevention to survivorship. So we've broken it down into 4 sections: biology, etiology, prevention, early detection, treatment, and then survivorship and recurrence. We really try to support our patients, and this isn't directly research, but we provide a service. It's an online tool called the Clinical Trial Finder, where we hand curate ongoing clinical trials from clinicaltrials.gov. We have staff that actually comb through the clinical trials that are available on clinicaltrials.gov to find trials that's specific to the CRC community. And we designed this tool to kind of make it easy for people to look up trials, and they can look in their area. They can look specific for their disease state or biomarkers that are present in their specific tumor, and find clinical trials that are hopefully recruiting actively and, get them access to treatment that they may not otherwise have had. And we also provide research grants to researchers in a variety of areas. So we're an advocacy organization, but we believe advocacy will lead to research. Research will lead to a cure, and hopefully no one has to deal with this going forward.
And Zach, you mentioned that the perhaps information available for a section on survivorship. And I wanted to have you maybe just speak to what that looks like as far as post-treatment and survivorship issues.
Sure. So there's, I think this probably is fairly common for most cancer types, but there's some really specific ones for colorectal cancer. I mentioned earlier, just briefly, ostomies and stuff like that. There's a lot of body image issues that go into post-treatment survivorship. A lot of people have self-image issues after, you've had several very large surgeries to remove either sections of your colon, and then you may or may not have an ostomy afterwards. And that's going to change how your life looks post-surgery, post-treatment. And, a lot of people find that the ostomy was actually, it benefits them in the long run. It makes their life easier to manage, makes their disease easier to manage, and makes them more comfortable moving forward. But there are certain image issues with that. You have an ostomy bag, it needs to be changed. You have issues with that. And there's also and this again, I feel like is probably fairly common across all cancer types, but anxiety related to follow-up scans and tests. We call it scanxiety. But, if you've been diagnosed and you're going on, you've completed treatment, you've been, no evidence of disease for however, you're still going to be getting follow-up scans, MRIs, CTs, what have you. And there's a lot of anxiety that goes into that whole process. As a test or scan approaches, it's just anxiety. You start letting your mind wander. The wheels start spinning, what ifs are all over the places. There's also, as we've been talking about earlier, John said, there's a lot of fertility issues that become issues, after treatment has ended. When you're diagnosed with colorectal cancer at 19 or 20, your physician is going to be focused on curing you, to keep you alive, to make sure that, this cancer is taken care of and we get you out of the hospital doors alive, breathing. But, some things that go by the wayside are, chemotherapy can ruin your chances to conceive children in the future. And not everyone is always informed of that when treatment is like, we need to get you in surgery right now. We need to get you on a chemo regimen right now. This is how we're going to save you. And everything else is secondary. So you encounter those issues as you get older. And if adoption isn't something that you want to consider, you need to address that before treatment starts, unfortunately. Like any other medical issue, there's financial issues, unfortunately, that can really come into play. The cost of treatments, the cost of being out of work, disability, that kind of thing can follow you for long after your treatment ends and you are clear of the disease. And this is an odd one that I've had a lot of people talk about. There's lots of social connections from people that ghost you essentially during treatment. You hear that story a lot where people lose their friends because they're sick and their friends don't know how to cope with it and deal with it. So they just ghost, and then you lose those social connections. And then there's just trauma and post-traumatic stress disorder and secondary diagnoses related to mental health and survivorship. You go through this whole treatment regimen, and afterwards there's before cancer, and then there's after diagnosis. And a lot of people have identity issues afterwards. You've been fighting cancer for so long, and after hopefully you were cleared and cured, who am I now? I've known cancer for so long and I've been in treatment for so long that you kind of have to find a new identity sometimes afterwards. And that can be really difficult, especially if you've lost those social connections and the people that you were close to before, if they've left your life.
Yeah, I think that some of those themes that I've perhaps encountered in my own practice is just that, those themes on body image and how that relates to sometimes social isolation. Just not necessarily wanting to meet friends for dinner, if they have to then go to the bathroom or then have any other care of their ostomy bags or some of these other worries associated with just being in a public space and then having that body image. Whether they're, those telltale signs of treatment of then hair loss or weight loss or a port or, it's something that else is this then part of active treatment.
Mm-hmm.
And like you were saying, some of these post-treatment then stressors that contribute to just having that social aspect and just impacted negatively.
Sure.
Curious if there's perhaps anything else that you want to share about the Colorectal Cancer Awareness Month?
So March is Colorectal Cancer Awareness Month in the United States, and Fight CRC really, this is our month. This is our time to shine. So we host a variety of programs in March. We have something specifically. It's called Call on Congress. It's March 9th through 12th, 2024 in DC. And this is really where we go to the Capitol and we try to meet with our lawmakers and make our voices heard in DC. We really try to make sure that policymakers are aware of how important research for this disease is. Colorectal cancer is the only top 5 diagnosed cancer that does not have a specific line item from the Department of Defense for funding. And we've been working to try to get that resolved for a long, long time, especially with, I mentioned the projections in 2030 that, it's going to be the number one cancer killer of people under the age of 50. And the fact that just enough research isn't being done is really critical. We also work very hard to distribute as many of our resources as possible during March and really kind of try to hit on the importance of screening, as soon as you're able to, and screening with appropriate methods. If you're 45, the screening age in the United States, if you're at average risk, the screening age has recently been lowered from 50 to 45 to try to catch more of these early onset cases when they're easier managed or easier to be managed. But that really, your screening age depends on a lot of things, and you should really be talking to your physician about when should I get screened? What's the appropriate method for me to be screened? All that stuff. Part of Call in Congress, we have a United in Blue campaign where we go on the national lawn and we display over 27,000 blue flags. That is symbolic of everyone that will die before 2030, that will die of this disease before 2030. And it's really just supposed to be a visual reminder. It'll sit on the mall and be very, very visible as people pass by the mall to make sure that, this is out there. It's in your face. We want people to be aware of this disease and know that everyone's at risk and that you really need to take care of yourself and get screened when you're able to. Get screened as soon as possible and continue to screen as recommended by your physician. March is really the big month for colorectal cancer awareness, but we are always working. We are always producing resources. We are always trying to get out in front of this and make people aware that this disease is at least somewhat preventable, and it's more preventable if caught early. And really, we're trying to get the United States government to do their part to fund the research for this, but there's also, personal accountability, and you need to take care of yourself and make sure that you're doing the best for your health, for your family, everyone. Just take care of your health, watch yourself, do what you can.
I was curious if there are specific then educational points that are offered for those patients that have those preconceived notions that, having a colonoscopy is somehow then related to sexual orientation, or that the presence of this diagnosis really only affects a certain group.
Yeah. So we, Fight CRC specifically, we produce a mountain of educational resources. Fightcrc.org is our website. It's a good place to start for all this. But we publish what I would consider somewhat cut and dry medical information that's supposed to be easy to understand for people of any background, to kind of help dispel some of these myths, really lay out what colonoscopies are and aren't, and really outline some of the alternative screening methods that are available besides colonoscopy, which, if you're interested, I'd like to talk about maybe perhaps just a little bit later. But we also produce our own magazine that we release twice a year. It's called Beyond Blue. And it really, we try to address some of these stigmas and really get the patient voice in these publications. Make sure people know that, this isn't, these stigmas follow, and that's why it's a stigma. It's not necessarily rational. It's not necessarily true, but they stick around and they're hard to address. So we really try to make sure that people are aware that this isn't anything besides a test for your health. It's no different than having labs drawn. It's maybe perhaps a little more uncomfortable because of the prep work and stuff like that goes into it, but it's just like anything else. It's like having your blood pressure taken. It's like having your lab work drawn. It's like any other test that you may or may not have had as you go through your life, and just really trying to make sure people understand that this is not a big deal. And it should just be part of anybody's routine checkups, especially when they hit age 45.
So there's really that attempt to normalize this as a common and routine procedure for overall health. You did mention that, if there are those perhaps hesitations to then having a colonoscopy, that there's are other ways that they can have that screening done.
Yeah, absolutely. And this is actually a really interesting area of research. It's really evolving as time goes on. But so, colonoscopy, it's the gold standard method. And the really great thing about colonoscopy is you have it. If there's any problems, if they see polyps, anything like that, they can address it right then and there. You're not coming back later to have polyps removed. They do it in one event, one setting, and you get your report right then and there. They send polyps off for biopsy, let you know what we're looking at. If it's anything's problematic, you can start the process pretty fast there. There's also some low cost options that are available. There's something called a fecal immunochemical test. It's called a FIT test. This is something where stool is collected at home, sent to a lab. It's low cost, and it looks for, essentially blood in your stool and other markers that might be indicative of colorectal cancer. It is repeated every year, where a colonoscopy is every 10 years. So it's something that needs to be done way more frequently than your colonoscopy would be. It can't really detect or remove polyps like a colonoscopy. And like almost any test, if something comes back suspicious, if the test comes back positive, you're going to get a follow-up colonoscopy anyways. So it's also something called multi-target stool DNA. It's like Cologuard. You've probably all seen those advertisements on TV. It's kind of similar to a FIT test in that stool is collected at home, sent to a lab. It looks for blood and DNA markers associated with colorectal cancer. Cologuard specifically can detect some polyps, but it can't remove them again. And if it comes back positive, like the other test, you're getting a colonoscopy afterwards anyways. And a lot of these are, covered by insurance, but not in necessarily every situation, whereas a colonoscopy at 45 is covered as preventative screening. There's also a couple non-invasive, or at least one non-invasive option. It's called a CT colonography, where your actual colon is visualized with a CT scan, or like you'd get a head CT, anything like that. It's not invasive. It is ionizing radiation, which, you try to limit how your exposure to that. Again, can't remove polyps. Colonoscopy is required if anything abnormal comes back. And this is generally a test for people that cannot tolerate a colonoscopy. If they have any other underlying medical issues, anything like that, they may be eligible for a CT colonography. But really the biggest takeaway with all these screening options, and it can be kind of overwhelming. You've got all these different options. What requires prep? What doesn't? How do I do this? Do I have to handle stool at home? This is really something we encourage people to talk to their physician about. Find the test that works best for you, for your situation. If you're high risk, you're probably not going to be eligible for anything besides a colonoscopy. If you have a family history of the disease, you're probably not going to be eligible for anything besides a colonoscopy, just because you're already predisposed to the disease. But this is something that a decision can be made with your physician after having a conversation, find the best fit, just get screened. Really, it's the bottom line is we just want you to be screened. If you catch it early, great. You're in a way better position to address the disease than if you would let it go, hadn't been screened, and they find you at stage 3 or 4.
Absolutely. Like, that detection is key. One odd thing that I had kind of forgotten about, but I had this idea, well, maybe in the future we'll have these smart toilets. They're smart everything, right?
Yeah, right.
So if it would limit that need to then handle any fecal matter, and
Sure.
if the toilet could then catch all that and then send it to the lab, or at least analyze it, I don't think that's too far off in the future, right?
No, that'd be amazing. I mean,
I'm going to trademark that. The Smart John.
There you go. I like it. Yeah, you should write that down, get it in the patent office. I know toilets are getting pretty advanced, so that'd be pretty impressive.
It's very silly, but just thought that I had just reminded of, in talking about this, that like maybe there was or will be a way to then have that not be as evasive and having that test done. But maybe just that's thinking outside of the box a little bit. But I wanted to ask if there's anything else that you wanted to then just wrap up with for today.
My biggest takeaway is that, and I just said it, but get screened. This is something that people are aware of, and they're aware of the issues and the worries about preparing for a colonoscopy, or, you mentioned handling stool, which I would like to say these tests that do have you send off stool to a lab, it's not like you're having to reach down into the bowl. You go to the bathroom and push something out and throw it in a Ziploc bag. Yeah, you're not actually touching anything. So if I can kind of temper any worries like that, I'd love to take the opportunity to do it now. But get screened, really address this, face this head on, just like you would with any other medical test. It's no different than anything else. It's no different than, I think I may have broken my arm. I need to go get an x-ray. I am at appropriate screening age. It's time to go get screened. It doesn't need to be a big to-do. And, it comes back negative. You're good to go. 10 years later, get screened again, do your prep, which I would like to address that. People tend to really worry about the prep for colonoscopy. I don't know if anybody on this call has had a colonoscopy, but that's the number one thing we hear people. They're horrified of the prep. They've heard horror stories that you've got to be, you're not leaving the toilet for days, and you're just going to be depleted after you've cleaned out your colon. There are options for prep besides the typical drink 2 gallons of fluid and sit on the toilet for days. So again, talk to your physician. Really get, this field is advancing quickly. Changes come quickly, and your physician hopefully is on top of things and is aware of the options that are available to you. But just get screened. It's the big thing. Prevent it, catch it early if you've got it, and then family can be better prepared for any potential issues moving forward when they need to get screened. So it's, just awareness. We really work on awareness. We try to destigmatize the disease. Just like any other cancer, you need to treat it head on, take care of yourself, and try to catch it early. And
yeah, one thing that reminds me of, and maybe you have seen this movie, I believe it's called Ghost Town with Ricky Gervais.
Exactly right. And generally, you're not even going to remember the actual procedure. They give you medication, it's not something they want you to be awake for and fighting for. So it's, you prep, you're in, you're out, go home, go have a good meal.
Yeah. There's actually in a self-help book that recommending getting colonoscopy like every 2 to 5 years. They're like, yeah, afterward you feel light and you'll be more successful. And it's like, wow, okay.
Yeah, I'm not sure that's really supported by the medical literature every 2 to 5 years, but 10 years for colonoscopy. But yeah, go get one. And if you feel great afterwards, then great. Like if you get that feeling of lightness and that you've done something good for your health, then great. Yeah. Anything I can push to encourage people.
Well, thank you so much for joining us, Zach. And,
absolutely.
Doing all the great work that you're doing at Fight Colorectal Cancer.
Yeah. Thanks so much for having me. This was enjoyable. And if anybody listening has any questions about Fight Colorectal Cancer or colorectal cancer in general, you can always reach out to patientinfo@fightcrc.org. You'll probably get me directly or one of my teammates. But I'm always happy to help with any questions that I can provide. We're not physicians, we're not doctors. Can't give you medical advice, but I can hopefully dispel some misconceptions about what it is to be screened for colorectal cancer and your options once you have been screened or diagnosed if it's come to that.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.